Good evening, everyone, and welcome to the Medusane Forum. It gives me immense pleasure to introduce Medusane, a platform that has rapidly grown to become a trusted educational partner for medical students across the country. Our mission is simple to provide accessible, high quality educational resources that empower students to excel in their academic and professional journeys. As we approach the second day of World Diabetes Day series, we are reminded of the importance of awareness, education, and collective effort to combat the one of the world's pressing health challenges, that is your diabetes. Through this series, our goal is to bring together experts in the field to share a valuable insights that will empower health professionals, students, and broaden the community to tackle the diabetes more effectively in their daily practice. Each sessions are designed to address the crucial topics from the basics of insulin to the pathophysiology of diabetes mellitus to the advancement of management strategies along with the latest guidelines. As we approach the day two, we are very happy that about 250 registrations have come so far, and all the students are encouraging us to do this series in much a broader scale. Today's topic is crucial for building a deeper understanding of diabetes, going beyond the symptoms and management to explore the fundamental biological process that leads to this condition. By grasping the pathophysiology, we gain the insights into how diabetes develops, progresses, and affects the multiple systems in the body. Today, we are honored to have our own advisor, Dr. Jamuna Rani ma'am, with us. She serves as a professor and head of the Department of Pathology in Bharat Medical College and Hospital, Chennai. Dr. Jamuna Rani ma'am is distinguished educator and expert in pathology, known for her in-depth knowledge and dedication to the medical education. She serves as a coordinator of IMA Medical Students Network Tamil Nadu and mentoring numerous students from different medical colleges in the field of research and innovation. She has published great research articles in various national and international journals, and I'm sure that today she is going to share her knowledge and she is going to give a great insight on the pathophysiology of diabetes mellitus as we rightly call upon it as understanding the roots. Thank you, ma'am, for joining with us today, and the session is all yours.
Thank you very much, Raghu. So this particular session, it will be a very short session for around 15 to 20 minutes. But if you can understand this session, definitely you will be able to relate the clinical features and relate why the complications happen, and you will be able to customize the treatment based on that. So as rightly coined, understanding the roots. So if you can understand this topic, definitely you will be able to definitely understand the basics of diabetes in a much better way. Yeah. So is the screen visible?
Yes, ma'am.
Okay. So without further ado, we'll start the topic, that is pathology of diabetes mellitus. So as all of you are already aware, so what is diabetes mellitus? It is a disorder of metabolism. The key feature is hyperglycemia. And why hyperglycemia? Because it is relative or absolute deficiency of insulin. So absolute deficiency of insulin in type 1 diabetes, relative deficiency of insulin in type 2 diabetes mellitus. And so because of this hyperglycemia, what happens? These long-term complications involving blood vessels, kidneys, eyes, and the nervous system. So as you are all aware, diabetes mellitus means sweet urine. So these are all the incidence and prevalence. All of you are aware. India being the diabetes capital of the world, and incidence is increasing alarmingly, and most common non-communicable disease. Why we are very much bothered about diabetes? Because diabetes with hypertension, it forms a deadly combination. And diabetes being an immunocompromised state, so it is very difficult to treat people with diabetes, especially in the era of oncology. people with diabetes, when they get cancers, it is really very, very challenging. So all these things make treatment of diabetes really very challenging. And that's why this particular month, we are celebrating November 14th as a, sorry, November 12th as a World Diabetes Day. It is very, very significant. Definitely high morbidity and mortality, and it is a leading cause of blindness and kidney disease. End-stage renal disease, the most common cause being diabetes. It is very crucial to control diabetes because the healthcare cost for renal disease, especially due to diabetes, is very, very high. Before getting to the topic, I want all of you to pay attention to this particular slide on normal pancreatic islets. So as you can see here, so this picture, this shows the alpha cells which secrete glucagon, and this picture shows the beta cells which produces insulin. So this is basically an immunohistochemistry picture with the strain. So usually IHC slides will have this brown color, and these are the alpha cells. As you can see the picture, they are very minimal, and these are the beta cells in the islets. So coming to the action of insulin. So what does insulin do? It takes glucose and also amino acids from the peripheral tissue, and the excess glucose is stored in the skeletal muscle and liver in the form of glycogen. So basically, insulin converts glucose into glycogen and stores it in the skeletal muscle and liver. It also converts the excess glucose into triglycerides. So basically, it is fatty acid synthesis, and it also aids in protein synthesis. So the amino acids will be converted into complex proteins. So what happens in diabetes? All these actions of insulin will not be there. So what happens? Diabetes is a state of increased metabolism. So as you can see here, glycogen formation will not be there. So the person will have hyperglycemia. So the problem in diabetes is because of hyperglycemia. Similarly here, conversion of glucose into triglyceride. Because triglyceride protection is not there, fatty acid synthesis is not there. In turn, fatty acid breakdown will be there, causing lipolysis. Similarly, because insulin is not acting well, protein synthesis will not be there. So what happens? All the protein will be broken down in turn into amino acids. So hyperglycemia, lipolysis, and decreased protein synthesis will be there. So this is the action of insulin, and because insulin is not acting well in diabetes, you have these three things. So the disorder in carbohydrate metabolism in the form of hyperglycemia, problem with the fat metabolism, so there is a lipolysis, and problem with the protein metabolism, there is a decrease in protein synthesis. So the complications of diabetes will be because of these three things. So the clinical presentation, you are all aware, there will be polyuria, polydipsia, and polyphagia. So why these three things happen? What is the pathophysiology? So what happens? Basically, there is a hyperglycemia. So what happens? The kidney will be able to filter only a limited amount of glucose. So beyond that, it will be excreted in the urine. So the renal threshold for glucose is exceeding. So what happens? There will be osmotic diuresis. So what do you mean by this osmotic diuresis? Whenever glucose molecule is getting excreted, in addition, along with glucose, what happened? Water will also be excreted. So that is the reason for the sweet nature of the urine. So that is causing polyuria. The sweet urine is getting excreted. So because a person is having a polyuria, what happened? Because water is also lost, the person will have dehydration. So the thirst will increase. So that will cause a polydipsia and polyphagia. So another reason for polyphagia is that because there is a lipolysis and also protein breakdown is there, so the person tends to eat more in order to have more of fat and protein in the body. And also, despite being having a hyperglycemia, what happened? So that excess glucose is not being utilized. So the body senses that as a starvation. So that is the reason for the polyuria, polydipsia, and the polyphagia. So in the pathophysiology, the first thing that will happen will be polyuria, followed by polydipsia, followed by polyphagia. See, this lipolysis will lead on to hyperlipidemia. So what happened? There will be rapid wasting and weight loss will be there in a person with diabetes. Again, amino acid metabolism is not acting well, not more protein synthesis is also there, which also lead on to rapid wasting and weight loss. So that's what we say in diabetes. It is starvation amidst plenty. Though there is plenty of glucose in the circulation, the body is unable to utilize it. See, this is a very, very basic slide which you need to understand. So what will be the first clinical presentation? It will be polyuria, followed by polydipsia, followed by polyphagy. So coming to the classification of diabetes, I know in the upcoming sessions, so this will be dealt in detail, but please understand this basic classification. Basically, we divide diabetes into primary and secondary. So what is primary? Primary is immune or non-immune mediated, whereas secondary is very rare. It is not due to defect in the insulin. It is due to the antagonizing other hormones like glucagon, VIP, all those hormones acting on which lead on to secondary diabetes. So secondary diabetes is a very miscellaneous category. So in primary diabetes, if it is immune mediated, it is type 1, insulin dependent diabetes mellitus, which is immune mediated. Non-immune mediated is type 2, non-insulin dependent diabetes or adult onset. We have a special category that is MODY, that is maturity onset diabetes of young, and finally gestational diabetes. So whatever the most common type of diabetes we see is a primary diabetes, out of which the most common is type 2, that is non-insulin dependent diabetes mellitus. Secondary diabetes is rare. Okay. So coming to the pathogenesis of type 1 diabetes, which is immune mediated. So what happens? Genetic is the most important thing in type 1 diabetes. To be specific, so this is a very important NEET MCQ. It is HLA-DR3 bar 4. So this is a genetic predisposition. So remember, a person with the genetic defect in HLA-DR3 or DR4 alone will not cause type 1 diabetes. So it needs a trigger. So here, what is the trigger? It is the environment. Usually virus, Epstein-Barr, Coxsackie virus. So a child can have the first episode of, the first clinical preponderance of type 1 diabetes will occur in a child, usually following a fever. Fever, probably a viral infection would have caused a fever. So which would be the environmental trigger, usually in a type 1 diabetes. So the environmental trigger viral infection would be there. So what happens? So this would have triggered with the genetic susceptible individual leading on to autoimmune insulitis. So what do I mean by autoimmune insulitis? So autoantibodies will be formed against either the beta cells of the islets of Langerhans or the insulin that is being produced. So it can be because of antibodies to either the beta cells or antibodies to the insulin. So because of that, what happens? So there is an autoimmune destruction. So there is a deficiency of insulin. So beta cell destruction will happen, leading on to insulin deficiency. So that insulin deficiency causes type 1 or insulin dependent diabetes mellitus. So what will be the histopathology picture? So you see a picture like this. So this is actually the picture of the pancreas, exocrine pancreas. See the exocrine pancreas, the dark colored cells will be the exocrine and the pale staining cells are the endocrine part. In the endocrine part, whatever the dark blue color which you are seeing are all the lymphocytes. So autoimmune destruction is there. So this is the pancreas. These are all the exocrine. The pale staining is the endocrine. In the endocrine, you can see the dark blue lymphocytes. So this is a classic picture of type 1 insulin dependent diabetes mellitus. There is an autoimmune destruction of the endocrine part of the pancreas. So this is the pathogenesis of type 1 diabetes mellitus. Moving on to type 2 diabetes mellitus. So here also there is a genetic or a beta cell defect will be there. Remember, see the genetic basis in type 1 diabetes. See, genetic with environmental trigger is there in type 1 diabetes. In type 2 also definitely a genetic basis is there. However, in type 2 it is polygenomic. Many genes will be responsible. Most important MCQ between type 1 and type 2, I would tell you. Genetic preposition for diabetes is very high in type 2 compared to type 1. please understand this concept. If a mother or father of a person is having a diabetes, type 2 diabetes, the chance of the child having a type 2 diabetes at around chance of a person having a type 2 diabetes at around 40 years of age will be around 80%. Whereas a family with either of the parent with type 1 diabetes, the chance of a child getting the type 1 diabetes is hardly 20%. So the genetic basis is more for type 2 diabetes. So there will be polygenomic factors will be there. In addition, the most important thing is obesity and lifestyle factors like smoking, alcohol, sedentary lifestyle. So all those things added up. So there is a insulin resistance. It means the beta cells are producing insulin. However, there is no peripheral uptake of insulin. So the insulin receptor in the peripheral tissues are not able to take up the insulin. So there is an insulin resistance. So how the pancreas will react to this insulin resistance? It tries to produce more insulin, isn't it? So the pancreas beta cells will try to work, trying to produce more insulin. So they keep on overworking. However, what happened? There is a peripheral resistance. So despite having more insulin by the beta cells, it is not going to act because it is the peripheral cells which are resisting the insulin. So what happened after some time, the beta cells gets exhausted. So the beta cells getting exhausted, the beta cells later on will not produce insulin. So this is the pathogenesis of type 2 diabetes. So insulin resistance will be there. So there is a relative insulin deficiency. Whereas in type 1, it is absolute insulin deficiency. It means insulin will not be produced in type 1 diabetes. Whereas in type 2, insulin is produced. In fact, insulin is produced in excess. However, since the peripheral tissues are resisting, it is basically a relative insulin deficiency. So what happened? The beta cells initially trying to combat the insulin resistance by overacting. So the beta cells will undergo hypertrophy and they try to produce more insulin, but after some time the beta cells get exhausted. So this is the etiology of type 2, that is non-insulin dependent diabetes mellitus. So what will be the histopathology picture? Again, the same picture. So the periphery or the exocrine part of the pancreas and the center is the endocrine part. As you can see here, the endocrine part, you see here eosinophilic acellular area. Very important NEET PG slide. So this acellular area is amyloid deposition. So amyloid will be deposited in the later stages of type 2 diabetes mellitus in the endocrine pancreas. So whenever a picture like this is posted, it means it is a type 2 diabetes mellitus with endocrine pancreas being replaced by amyloid deposits. Okay, so the same picture with lymphocytes being there, it is type 1 diabetes. With acellular pink area like this, it is type 2 diabetes. So what are the difference between type 1 and type 2? Onset less than 20 years. Type 2, it is more than 30 years. So here type 2 has a strong association with obesity. Insulin levels, as said, there is an absolute insulin deficiency. So insulin levels will not be detected, markedly decreased, whereas here normal or increased. When the beta cells try to produce more insulin as a compensation, it will be increased. So anti-islet cell antibody will be present in type 1, type 2 it is absent. Diabetic ketoacidosis, the most common complication, acute short-term complication of type 1 diabetes is diabetic ketoacidosis. Whereas in type 2, the most common short-term complication is hypoglycemia followed by non-ketotic hyperosmolar coma will be the most common short-term complication of type 2 diabetes. See, this is what I've been discussing, twin concordance. So twin concordance for 30 to 70% for type 1, whereas see here for type 2, it is 50 to 90%. So the genetic association is more with type 2 than with type 1. Type 1, it is MHA class 2 genes, whereas type 2, there are multiple number of genes not yet mapped. Here it is autoimmune destruction of the beta cells. Here it is a peripheral insulin resistance. So what will be the morphology in islet cells? Here it is early insulitis. Itis means inflammation. So the insulin producing cells will have inflammation. So because of repeated inflammation, what will happen? Because of repeated chronic inflammation, like any chronic inflammation, there will be atrophy and fibrosis will be there. beta cells will be totally depleted. When we do immunohistochemistry, we won't be able to see beta cells at all. Whereas in type 2, there won't be any insulitis. So later stages only, there will be focal atrophy. The most important thing will be amyloid deposition will be there. Since there is a beta cell hypertrophy will be there, later stages, because of amyloid deposition, only mild beta cell depletion will be there. So far what we have understood is in diabetes, either it is absolute deficiency of insulin in type 1 or relative deficiency of insulin in type 2. So in type 2, what happened? It is basically insulin resistance. So what this insulin resistance does? So what do you mean by insulin resistance? It is a decreased ability of the peripheral tissue to respond to insulin. So that is what is meant by insulin resistance. So what happens in type 2 diabetes? What happens? So there is increased level of free fatty acid. As I said, there is a lipolysis. So the insulin is unable to convert the free fatty acids into triglycerides. So what happened? There is increased level of free fatty acids. So this free fatty acid will cause a lipotoxicity. And another thing in obesity is there are a lot of cytokines released from the adipocytes. See, one very key important feature I want all of you to remember. These days, adipocytes are also called as endocrine organ. It produces lot of hormones like adiponectin, leptin, and resistance. So these are all the adipokines. Leptin, adiponectin, and resistin are all the adipokines which are produced from the adipocytes. So all these cytokines will in turn make more insulin resistance. So it is like a double-edged sword. Diabetes, because of insulin resistance, lot of free fatty acids is being produced. So these free fatty acids in turn increase the insulin resistance. Similarly, the cytokines released from the adipocytes in turn increase insulin resistance. And the most important thing, lot of research is happening in this area only, is PPAR gamma, which is nothing but peroxisome proliferator activator receptor gamma. So this is basically very good. So the most common drugs which is used in diabetes, that is thiazolidinediones. So this thiazolidinediones basically increase the receptor for this PPAR gamma. So this basically goes and modulates the gene expression in adipocytes. Thereby, it decreases insulin resistance. So a very potential drug target is this PPAR gamma. So a little bit about this MODY, that is maturity onset diabetes of young. So what you have to remember here is, see, type 1 diabetes, it is basically HLA. Type 2 diabetes is polygenomic, whereas maturity onset diabetes is basically an autosomal dominant inheritance. So these people will be usually lean, absence of obesity will be there. And how do you differentiate from type 1 diabetes is lack of islet cell antibodies and insulin resistance syndrome. So lack of islet cell antibody will differentiate it from type 1, and insulin resistance syndrome will differentiate this MODY from type 2 diabetes. So in maturity onset diabetes of young, 6 genes are identified, and these days we have targeted therapy, tailor-made therapy. So a new branch of medicine called targeted or customized therapy, the way we wear our shirts customized to our size. So it is targeted therapy is available. So that branch of medicine is called theranostics. So especially for maturity onset diabetes of young, there are 6 subtypes. So especially this HNF4A in maturity onset diabetes of young type 1. So there are specific targeted therapy available for this. So similarly, MODY2 is because of glucokinase 3, 4, 5, and 6. So specific therapy is available for this HNF4A. Remember this. So these are all the miscellaneous genes. You know that mitochondrial inheritance also causes diabetes. So these are all the rare causes of diabetes, which we are not going to look into it. Similarly, gestational diabetes will be dealt in detail. But remember, glucose intolerance especially develops during the pregnancy. It is basically because of HPL, human placental lactogen. And the most common issue with gestational diabetes is macrosomia, respiratory distress syndrome, neural tube defects, and TGA, congenital cardiac disease. So these things again will be dealt in detail. Coming to the complications. So complications I'm not going to touch in detail, but I will tell you the pathogenesis of these complications. So as discussed already, short-term complications are due to metabolic, most common being hypoglycemia, diabetic ketoacidosis in type 1, non-ketotic hyperosmolar coma in type 2 diabetes, lactic acidosis. Long-term complications, angiopathy, especially angiopathy into two types. One is micro, other is macro. Macroangiopathy will lead on to atherosclerosis. Microangiopathy is the risk factor for retinopathy, nephropathy, neuropathy, and dermopathy. So diabetic nephropathy, again, the most sought topic. So I will just explain from the pathologist perspective. So as you are all aware, this is a normal kidney. So these are all the glomeruli, and in between are the tubules, and the space in between the cells in between the tubules. So this is the interstitium. And you will see the blood vessels as well. I'll show you a better picture. So this is a high power view of a glomeruli. So this is a glomeruli, and these are all the tubules. And in between the tubules is the interstitium. When you look into the glomeruli, so this space, this is a urinary pole. This is a Bowman's capsule, and this is a urinary pole. And all these round empty spaces are the fenestrated endothelium. And through this lumen only, the urine will be excreted. And all this fenestrated endothelium will have the endothelial lining. Endothelial lining is difficult to see under routine microscope. They are all, you can see here, this is a flat endothelial cells. And the big cells are all the mesangial cells. All these round cells are all the mesangial cells. So what happens in diabetic nephropathy? The changes in diabetic nephropathy will affect the renal glomeruli, will affect the renal tubule, will affect the renal interstitium, will also affect the renal blood vessel. As you can see here, renal blood vessel is affected. You know, it is a medium-sized vessel. When the bigger vessel is affected, it is atherosclerosis. When a medium-sized vessel is affected, it is arteriosclerosis. So hyaline deposition around the renal vessel will be there, which is called hyaline arteriosclerosis. The problem in the glomeruli, so initially there will be diffuse mesangial sclerosis. See, as you can see here, the cells here are the mesangial matrix. So in diabetic nephropathy, what will happen? So the mesangium will be sclerosed. So mesangial cellularity will decrease, and there will be a pink hyaline material will be there, which I will show you. After some time, what will happen? So this diffuse will join together to form a big nodules in the glomeruli, which is called nodular glomerulosclerosis, which is also called as Kimmel-Still-Wilson lesion. And you have pus-like exudative lesion. These nodules will exudate, leading on to exudative lesion. These are all the changes in the glomeruli. I'll just show you the picture. So this is a glomeruli. As you can see, the urinary flow is widened here. So the glomeruli is shrunken. See, the movement space has detached. And as you can see here, the mesangial cellularity is decreased. And you see this pink material in the glomeruli. So this looks like a nodule, isn't it? So this is one nodule, this is another nodule, this is a nodule, this is a nodule. So this is the typical lesion of Kimmel-Still-Wilson lesion or nodular glomerulosclerosis. In the same picture, what you see here is a blood vessel with hyaline arteriosclerosis of the blood vessel. So this is a typical lesion in diabetic glomerulosclerosis. So the changes in the glomeruli, diffuse mesangial sclerosis followed by nodular glomerulosclerosis. The change in the blood vessel in the renal artery, it is hyaline arteriosclerosis. In addition, diabetes people will have a high risk of urinary tract infection, especially pyelonephritis. When the infection ascends from below, it will lead on to infection of the kidney, that is pyelonephritis, followed by all the renal papillae will undergo necrosis, which is called necrotizing papillitis. So diabetes will affect the entire kidney, glomeruli, tubules, interstitium, renal blood vessel, everything will be affected in diabetes. So other Complications, I'm not going to go in detail. I'm going to tell you the pathogenesis alone. Similarly, diabetic microangiopathy, the risk factor for diabetic retinopathy, neuropathy, all those things. So diabetic microangiopathy, this is a blood vessel, and the green color is the endothelium. So here, what happens in diabetic microangiopathy is, so this is a normal blood vessel. So because of hyperglycemia, so this excess glucose is staying in the blood vessel. So what happened, that excess glucose will degrade into advanced glycation end products, AGE. So this advanced glycosylation end product will be depositing in the endothelium. So this lead on to basement membrane damage, leading on to leaky endothelium. So all these things will cause endothelial dysfunction. So these three arrows represent the leaky endothelium, leading on to endothelial dysfunction. You can see the lumen of the vessel is narrowed. And what happened? The surrounding the blood vessel, there will be hyaline deposition. To be specific, hyaline deposition will happen in the tunica media of the blood vessel. Around the tunica intima, then you have the media, then you have the adventitia. So in the tunica media, you have a hyaline material deposition will be there in diabetes. Because see, why this hyaline deposition is happening? Because it is getting leaky. You need something to seal the defect, isn't it? You want to guard the endothelium. So the body acts as a defense and tries to have the hyaline material surrounding the tunica media and trying to seal the defect. Unfortunately, what happened? So this hyaline thickening leading on to narrowing of the lumen. So more narrowing of the lumen is happening. See, this is a electron microscopic picture. As you can see here, so this is the endothelial lining, and normally the endothelial lining will be a thin line. So whatever you see here, all this things are the advanced glycosylation end products and glucose getting deposited over here. You can see here, there is a defect here. So this is a basement membrane damage and leak. And this area where I'm pointing, so this is a tunica media, and this is a tunica adventitia. So this tunica media, as you can see, the dark hyaline deposition in the tunica media. So this is the pathogenesis of diabetic microangiopathy. And remember, diabetic people are more prone to infections, not only UTI. Definitely, you have to remember fungal infection. So this picture again, very important NEET PG question. So this is basically the candidiasis. Okay, so this is the candidiasis of the candidiasis, the most common complication seen in diabetes. So coming to the other complications. So in the blood vessel, it is basically the glucose and the advanced glycation end products causing damage of the basement membrane of the blood vessel, causing an endothelial dysfunction, leading on to a leaky endothelium. In order to seal the defect, hyaline is getting deposited around the blood vessel. So that is the reason for diabetic microangiopathy. So what are the things that is happening? What are the complications is? The pathogenesis is because of non-enzymatic glycosylation, disturbance in polyol pathway, very important, especially in diabetic retinopathy, activation of protein C. So these three are the most important reason for all the complications of diabetes in the entire body. I'll just brief these three things alone. So non-enzymatic glycosylation. So what happens? Glucose will combine with amino acids in the protein, because I told you that more of amino acid is being there. Protein catabolism is happening in diabetes. So what happened? The excess glucose in the blood vessel with the amino acid combine to form advanced glycosylation end products, which we have already said that alters the vessel permeability, making the vessel leaky, causing increased atherogenesis, leading on to hyaline arteriosclerosis. And in the major vessels, it is atherosclerosis. So this particular reason, that is AGE, is a reason for diabetic micro and macroangiopathy. Disturbance in polyol pathway. So what is this polyol pathway? What happens? Normally, glucose, when it is not being converted into glycogen, will be initially converted to sorbitol by aldose reductase. This sorbitol will be converted to fructose by sorbitol dehydrogenase. So in diabetes, what happens? Because glucose is not getting converted to glycogen, more of sorbitol and uh, fructose is getting synthesized. So this sorbitol and fructose are osmotically active. It means these molecules will attract lot of water. So this draws the water into the tissue, leading on to tissue edema, especially in diabetic retinopathy again, tissue edema. So that edema will compress the nerves, leading on to permanent damage. So this is the polyol pathway. Remember all sorbitol. Okay, so sorbitol and fructose attracts more water, leading on to more water within the tissue, causing permanent damage to the tissue. So this etiology is responsible for the peripheral neuropathy, cataract especially, and microaneurysms happening in the retina in diabetic retinopathy. The last one is activation of protein kinase C. So what is this protein kinase C? What happened? You're aware that there is a lot of glucose is there. So there is a hyperglycemia is there. So this glucose will stimulate the synthesis of DAG, DAG, that is diacylglycerol. So from the glycolytic intermediates. So this diacylglycerol will lead on to activation of this protein kinase C. Okay, so this protein kinase C, what it does is it goes and stimulates vascular endothelial growth factor. See, this protein kinase C will basically activate the DNA, leading on to cell cycle activation. So this protein kinase C, normally you would have studied PKC in normal cellular metabolism. Here, what happened? There is like neoplasia. Here, there is an uncontrolled activation of protein kinase C. This protein kinase C goes and activates vascular endothelial growth factor. So this vascular endothelial growth factor, what it does? Vascular endothelium. So what happened? It causes neovascularization. See, the normal role of protein kinase C will be there in wound healing. Normal wound healing, protein kinase C will be there, will lead on to activation of vascular endothelial growth factor, causing neovascularization of the injured area. Here, what happens? Because of the inappropriate activation of PKC, neovascularization in the retina is happening. Also, extracellular matrix and basement membrane deposition will be there. So extracellular matrix and basement membrane deposition will be there. And here what happened? There is a reduction in fibrinolysis. So normally what happens whenever the fibrin is deposited, the blood clot will be formed. After some time, the fibrin should get lysed. So here the fibrin is not getting lysed. So what happens? There is already an increased atherosclerosis in diabetes. So the normal fibrinolytic mechanism should activate, leading on to dislodgement of the clot that is being formed. Here, what happens? There is reduced fibrinolysis because of the activation of protein kinase C. So this reduced fibrinolysis causes vaso-occlusive episodes. Means there is an increased atherosclerosis and reduction in fibrinolysis is happening. So what happened? The clot that is formed will stay on forever, leading on to lot of vaso-occlusive episodes. So to conclude, type 1 diabetes, it is because of absolute deficiency of insulin. Type 2 diabetes, it is because of relative deficiency of insulin. Insulin in excess, but the periphery is not active. Remember, type 1 and type 2 are examples of primary diabetes. Secondary diabetes is because of insulin antagonizing hormones. Okay. And the most important mechanism for type 1 diabetes is HLA mediated, followed by environmental trigger. Whereas for type 2, it is polygenomic. However, the added risk factors would be lifestyle factors, obesity, smoking, a lack of exercise, stressful life, all are etiology of type 2 diabetes. Coming to the complication, the three reasons for the complications would be, as discussed, activation of protein kinase C, which is the most important culprit, disturbance in polyol pathway, and finally, it is the non-enzymatic glycosylation end products which goes and accumulates in the blood vessels. So with that, we are completing this pathogenesis of diabetes. Any queries here, you can definitely communicate in the WhatsApp group. We will be happy to answer. Over
Thank
to
you,
you,
ma'am.
Raghu.
Thank you, ma'am. Thank you so much. It was really a wonderful session. As we conclude today's insightful session on pathophysiology of diabetes mellitus, I would like to extend my sincere, heartfelt gratitude to Dr. Jamuna Rani ma'am for sharing a wealth of knowledge and breaking down the complexities of diabetes pathophysiology with such a clarity and depth. Your insights have truly enriched our understanding and highlighted the importance of addressing diabetes from the foundational perspective. So I think that with this knowledge, if they go from tomorrow for understanding the complications of diabetes mellitus, it will give them a great idea and insights and understanding. So tomorrow we will be having the first part of the complication, that is the diabetes and kidney by Dr. Reshmi ma'am, where she will be covering about the complications of diabetes with respect to the nephrology part. And thank you for all those who have joined today. Your active engagement and curiosity are what make these sessions impactful. We hope today's discussion has given you a stronger understanding of the roots of diabetes and inspired a new perspective on its management and prevention. Please remember to fill out the post-session feedback form, as these inputs will be helpful for us to continue such sessions and improve such sessions in the future. Once again, I would like to thank Dr. Jamuna ma'am, and thank you for all the participants for being a part of this journey. And we would like to see you back tomorrow for all these sessions. And as we have highlighted already, we are listing out those who are attending the sessions, and out of 10, at least 7 sessions are required for enabling us to provide with you all with a certificate of completion of this 10 days long journey. Thank you once again, ma'am, and thank you all.
Thank you.
Yes, ma'am. In Panta. இன்னைக்கும் பரவாயில்ல மேம். I think after a long